Good morning. It's Friday, October 25th, and I'd like to spend a few minutes in this video looking at the articles, some of the articles from segment 3, Social Cohesion, but do a little bit of background about how we got here and kind of keeping us in context, which since this course is about context. And I'd like to talk towards the end about the final paper, since the semester is coming rapidly to an end, maybe, 5 weeks away, 6 weeks away. This segment's about social cohesion and social capital. Now, what we've been seeing from, say, segment 1, which was our introduction, not the introduction, but the demographic segment, if you'll recall, we were looking for kind of contextual influences on mortality as the mortality rates were described in those articles. That was mining for gold. And we called it mining for gold because, for the most part, at the time, either the time those articles were written or the authors themselves were not particularly concerned or aware, maybe, of contextual influences on human behavior like we are now. Maybe they were an earlier generation, shall we say. So when we read those articles, we had to look through a lot of them. We had to really look and mine those articles for statements of gold. And gold would be the ZI, the contextual influences, those that they actually intentionally mentioned, or those comments about the ZI, so we call it ZI, but the contextual influences that they might have said in passing. And we found some gold in those articles. That was part of the exercise, was to realize that this is, I suppose in a way, this is a recently new phenomenon. Actually, it's come back around again over the last generation or so, say since the 1990s, introduced to a large extent by thinking in Europe, sort of by way of the School of Public Health at Harvard, Kawauchi, for example. And but really it was a characteristic of epidemiology generally in the 19th century, both here and in Europe, the contextual influences on health, population-based health, of course, is what we're always talking about. In this country we lost it in the 20s, 30s, and 40s. Part of it was, I think, sort of the Red Scare. Thinking of communal perspectives on health sounded too much like, communism. It's interesting, I may have mentioned this before, but the Bexar County Medical Society here in San Antonio was in the forefront in the 1890s and very early 1900s in talking about contextual influences on child mortality, particularly infant or very young children, looking at contextual influences, the lack of sanitation, and how that characterized neighborhoods, elevated the risk. But we lost that. They lost that to some extent, and have only recently begun to regain it. We, on this side of the Atlantic, are more individualistic, shall we say, so we see things as ecologically fallacious. You talk about ecology, well, it's not really about that. We see now in the medical schools that med students are being trained to look at the sociology and the contextual influences, and as we've said before, the medical college admission test in 2015, spring of 2015, will require students, if they want to pass the MCAT, to have a pretty good grounding in the social sciences, particularly sociology, and its look at the contextual influences on behavior. So anyway, that was what segment 1 was about. I think now we'll, if we were in future generations on this course, if they're looking at the papers that go way back to 2010 and 2012 and 2013, they'll find that there's a wealth of gold in the mines. Perspectives have changed. So, and then we went to segment 2, and thinking about that equation that we look at, the contextual influences, the sort of the sentinel effects in the intermediate level, and then the health outcomes. We posited the idea in segment 2 that it was income inequality. And indeed we know, it's clear, that health inequalities track income inequalities. I mean, it's just evident in every day's newspaper and on the radio, Time magazine, any place you look, but particularly in the science, evidentiary basis stuff that we're looking at. It's very clear how it tracks that, and we saw that in segment 2. And so our ZI was characterized by income inequality. We were using as our sort of thematic in that the Robin Hood Index. In those counties or states where the index was higher, in other words, a higher proportion of redistribution of wealth was required in order to get something more equally distributed. In those that had a high index were those also that had a high mortality rate. And so that was our argument there. And then the other part of that, which was kind of interesting, that if you'll recall, some of those equations, the more statistical pieces of those articles, when they put income in there and control for income, the health inequality remained to some extent. And that began to suggest that it's not just about income inequality. There's some other factor going on out there that's influencing health, not solely income. Perhaps income is a distal influence, perhaps, and the more proximate influence is something else. So anyway, what segment 3 is about is looking at that something else. Now, one way to visualize the transition from segment 2 to segment 3 is to go back to that Moody lecture that's posted on the website. There are two articles, or two Kawachi, I guess they are, not articles, but figures in there, Excel chart kinds of figures with an x-axis and a y-axis. One of those, and I think we've looked at one of them, is the Robin Hood Index on the x-axis, so that as income inequality increases, on the y-axis, the percentage of people who trust one another declines. So it's an inverse relationship. As inequality goes up, trust goes down. An inverse relationship. And then the other one that's on that Moody lecture that sort of makes a transition for us, there you see on the x-axis trust. As trust declines, mortality increases. So that's also an inverse relationship. As trust goes down, the mortality increases. That speaks to the cohesion aspect of this, which is the theme of segment 3. In the Berkman article and a couple of other articles in there, they talk about dimensions of social cohesion, interpersonal trust in a neighborhood, let's say associational behavior, and reciprocity. If I feel comfortable, do I feel comfortable going down the street and asking a neighbor to borrow an egg? If I see my neighbor across the street working on his car, will I go and help him out, or will he help me out? Are there gatherings in the neighborhood, associational behavior, where we hang together in one way or another? If I walk down the street, or if I'm in my backyard and my neighbor's in his or her backyard, in spite of the fact now we have 12-foot fences between us, right? Do I feel comfortable being in the backyard with my neighbor in the backyard? Or in the evenings at 8 o'clock after dark, at dusk, when I'm walking down the street, do I feel comfortable? Or is there sort of an implicit threat? Do I feel that little chill, that little adrenaline rush, the prickliness of the hair on the back of my neck? Those are measures of social cohesion. We've used them here in San Antonio in surveys. To what extent do you have interpersonal trust in your neighborhood? To what extent is there associational behavior? Kind of ordinal things from very much to not so much, and that sort of thing. And we find that there is an association with those kinds of measures and illness. So that sort of, you can think of then social cohesion then, whereas in segment 2 we were using ZI, income inequality as ZI. In segment 3 we're using social cohesion as a ZI. Where cohesion is high, autoimmune system stress is low, autoimmune system is not so adversely impaired, and health outcomes are better. Where social cohesion is down, stress is up, autoimmune system is impaired, and health outcomes are not so good. That's our basic argument. It's been an argument all the way through the semester from day one. So here then, the ZI in these papers that we're looking at is the social cohesion. And the three measures that are often mentioned in the articles are the ones we just talked about: interpersonal trust and associational behavior and reciprocity. So pay attention to those articles. We'll come back to them in segment 4, particularly the ones that have to do with the measurement of cohesion. But let's kind of see. I've got the notes that I just posted here. If we sort of covered that portion of it. Yeah. Oh, one thing I wanted to just highlight really quick is just, without going through each article, although I do want to talk about 2 or 3, just look at the titles of the articles, and you'll see that some of those articles hold the names of students that were assigned to this at the graduate level, and when I migrated, I didn't clean the titles of those articles off. So when we did them in the graduate level, we put student names on those things. So don't get confused about who wrote that article. Generally, the article titles out there, the first names are the student names, and the ones in parentheses are the actual authors. So I apologize for not being so clean in the migration. But if you look at the titles, they're highly suggestive of what we're doing this segment. Social ties in relation to coronary heart disease. So there we can just automatically imagine. Well, one thing you want to think about when we think of social ties and networks, which is leading us into the ZI in segment 4, we're thinking now it's social cohesion, and so it is. But then we begin to look at the dynamic inside social cohesion and realize that it's a fabric. It is a network of relational ties, and that's segment 4. So we go from income inequality, maybe not. Social cohesion, well, probably so, but what is that? To social networks in segment 4. And so that social ties in relation to coronary heart disease kind of leading into that, but it is speaking to the fabric of social cohesion. We can only imagine, without even reading the article now, where social ties are high, coronary heart disease is low. I mean, it just follows our hypothesis. We can just imagine what that article is about. Social capital and neighborhood mortality rates. Now, social capital is the action verb, shall we say, for social cohesion. What is social cohesion? Social cohesion is kind of a concept, but how do we operationalize it? And we operationalize it as social capital. And one way of doing that are those 3 dimensions. To the extent that there's interpersonal trust, associational behavior, and reciprocity, there's good social capital in a neighborhood, let's say. And social capital, again, is like human capital and financial capital. I've got some dollars in my pocket. That's financial capital. I can capitalize on that and go out and buy a cup of coffee or a sandwich or something. Human capital, you are in university, increasing your human capital. You're in that component that is educational level, and you're hoping that by getting a degree in sociology or in nursing, that you'll be able to capitalize on that and improve your circumstances in life. Maybe get some work that you really love to do and get on with your life. That's human capital. Social capital is the same kind of thing, but it's in an aggregate at the neighborhood level. If people are interpersonally trusting one another and they're associating with one another and they're reciprocal in their relationships, they feel good, and there's good networking. So if something comes in their way, say they want better lighting in their neighborhood, then because they're so kind of socially integrated, they might have a community meeting, decide that let's form a organization on behalf of ourselves and go to the mayor and say, look, we need lighting in our neighborhood. We see this in the community health assessments that we do. We just finished one this last month or so, and we're moving into the community health improvement plan. The neighborhoods that have good social cohesion and integration have good social capital, and they're very good at representing their interests. It's very powerful to witness when we're in the neighborhood. So here you can imagine social capital neighborhood mortality rates. Where capital is high, mortality rates are low. There again we see the hypothesis. Sampson's collective efficacy is another way, in a more measurable way, say statistical way, of capturing social capital. So to the extent that a neighborhood is collective, has social capital, then when they operationalize further social capital, they have collective efficacy. In other words, their actions are efficacious on behalf of themselves as a group. It's an interesting article, and we'll come back to that collective efficacy and the neighborhood effects article that's in this segment, and Prof's notes in a video next week. Kawachi's got an article there, Social Capital, Income Inequality, and Mortality. Well, now we're 4 or 5 into these articles. You can see, you know now, without even reading these, what's going to be the case. As inequality, the higher the inequality, the lower the social capital. The lower the social capital, the higher the mortality. In other words, it's more difficult to form form cohesion in a highly unequal community, at least across the entire community. Now, neighborhoods where the income levels are similar, now there's a cohesion that's possible there. But where there's across a city where income is disparate in its geographic distributions, wealthy neighborhoods, not so wealthy neighborhoods, and those in the middle, it's hard to bring that community together in terms of collective action. And so you might find in that kind of geographic inequality distribution, variation across an urban environment and mortality, and indeed we see that, say for example in these community health assessments we do here in San Antonio. Again, here's one that's more timely for us. Kennedy, Social Capital, Income Inequality, and Firearms. Now that we're in this course, we can imagine perhaps some of the theoretical, perhaps evidentiary basis of why we have firearm deaths, or deaths, use of firearms in crimes, and the kind of the murderous rate of firearm use in large quantities of people being killed with guns with clips of bullets in them. And then we see that Europe hasn't historically had that. But we're in a economic recession, depression. People are struggling. They're desperate. Health inequalities are increasing because income inequalities are increasing. Stress is high. So maybe to some extent what's going on in Europe is a reflection of the destruction or the disaggregation of a sense of cohesion in Europe. And people begin to do interpersonal violence, much like we've seen here in the United States for generations, even though we're one of the wealthiest countries in the world. Social disorganization and relative deprivation, that is, those are more sociologically criminological kinds of terms, but it's the same thing. Excuse me. Where there's no social cohesion, there's social disorganization. Socially organized is social cohesion. Social disorganization is lack of social disorganization, is lack of social organization, and then relative deprivation. So that's just another way of looking in a more technical way wherein inequalities exist in the way of income, then places are more likely to be socially disorganized, particularly if you look across an urban environment. And then the article there that is Social Network Stress and Health-Related Quality of Life. There you can see that's a transitional article into segment 4 where networks are good, stress is low, and the sense of self-assessment and health-related quality of life is high. What we have discovered, for example, in the 2013 Community Health Assessment, the self-assessment of health is down. In other words, over the previous assessments, going back, the first one we did in '98, and we've done 5 of them now, every 3 or 4 years, the self-assessment of health is down. More people are saying they don't feel well than in the past when they said they felt well. And they're also saying more about not feeling so well mentally, whereas in the past that wasn't quite so prominent in the response to surveys and conversations, listening to the community voice and qualitative interventions. So that is a reflection of some disaggregation of the sense of community in San Antonio, which is no different than in the United States or any place else in the world right now, because it's such a stressful place economically that the world is, and all the other parts of it. So we're beginning to see some of that disaggregation beginning to happen, the network, the fabric, beginning to tear just ever so slightly. in San Antonio, as evidenced by people's beginning to think there's more mental issues going on and less a sense of good health. Okay, so I think, let's see, pay attention, those of you who are not sociologists, but even those of you who are sociologists or familiar with the sociological literature, to the Berkman et al. Article on Emil Durkheim, Social Integration, Alienation, and Anomie. Those are sociological, psychological terminations of alienation. Another way of thinking about it is apathy. If we're not connected, then we're apathetic. If something happens in the neighborhood, what do we care? You know, if there's a shooting in the neighborhood, or we're not mindful of one another's children, we're not looking out for one another, we're feeling alienated, anomie, we're just not connected with anything other than ourselves, perhaps only with the TV and our iPads and video games and things like that. So take a look at that Durkheim article. It's a good theoretical grounding from basically in sociology for what we're doing, beyond what we've been talking about in terms of the social determinants in population public health. I think, and another way to think about this too is proximate and distal, and they talk a little bit about this. So if we've got social cohesion, and then behavior, and then outcomes, we might say that the distal determinants, influences, are the contextual ones that give rise to the more proximate ones, which are behavior, and then those more proximate ones give rise to the health outcomes. Proximate in the sense that it's the behavior more directly that gives rise to the health outcome, whereas in more remote distal way, the behaviors themselves are the product of dysfunction, let's say, or function of a neighborhood that's cohesive. So it would be, behaviors would be good. If the neighborhood is not so cohesive, the behaviors would not be so good. In that article, you'll see in my notes attachment theory of John Bowlby. Now that's a psychological look at this, how attached we are to one another and place. If we don't feel that attachment to one another, this is a sort of the psychological. That article, Berkman integrates very well sociological and psychological perspectives, and relates it psychologically to attachment theory, how attached we are to one another. So, and that is perhaps we could say, not the glue of the networks, but the product of the networks. Or, who's to say which comes first, chicken or the egg? But that attachment that we begin to have in socially cohesive communities is important in terms of our interpersonal trust. If we feel attached in our associational behavior, if we feel attached, if we're attached to the family across the street, we're more likely to walk across the street and say, "Hey, what's up today?" if we see them in the front yard. Okay, I think, and thinking about networks as fabric is a good way to think about it. The networks are the stitching, the threads of the fabric of society. It's a good way to think about that. So we're talking about social cohesion right now and demonstrating the power of it to explain health in a way that seems to touch us more deeply, perhaps in our hearts. Being social beings that we are, social cohesion resonates with us a little better than the more austere look of income variations and health variations. We can see the translation of that in terms of cohesion. So I think that's the power of this particular segment. We talked about the neighboring and social cohesion. We talked about the social capital, income inequality, and mortality, the Kouachi article already. Pay attention to those figures. Kouachi's a master of capturing this in figures. A picture's worth 1,000 words, right? If you look at Kouachi's figures, you get it quickly, like those two that are in the Moody lecture. I think then that's pretty much what I wanted to say. Segment 3, I just posted it. The due date is November the 8th. Segment 3 goes through Sunday of coming up, And so for discussions and stuff go on this week, and then you have a week to write the paper and post it for the 8th, and that next week we'll start segment 4. I'll post a video, some notes and video. I've already got the notes kind of drafted on the neighborhood effects, Sampson's article. I want us to think about that one as we come out. Now we get a sense of what social cohesion's about. At the end of this segment, it's a good place to do neighborhood effects. It's listed in there. You can take a look at it, and it's also posted at the very beginning in the syllabus, I think. But I'll do a video and some notes on that explicitly on that next week as kind of a transition into segment 4. Now, begin thinking about the paper. There are some requirements set forth about the comprehensive essay in the syllabus. What you're going to want to do is you're going to want to pick a theme of interest to you. It could be coronary heart disease, and write about that if you want to take a more physical health kind of thing. There are some articles coming up that have to do with mental health. There are articles particularly having to do with women and mental health. There may be an article on the workplace. Pick something that is resonating with you. It may be an article that you've written about that really got you thinking about this. So that article would be the central piece or the central thesis of your comprehensive paper, and then you'll pull other articles out of the readings. I really wouldn't want you to have to go to the trouble pulling articles anywhere else other than in our readings, unless you want to. I think you can build a literature review quite soundly with the articles that are represented in the various 4 segments of readings. So you'd want to put some literature review around that to make your argument, and we'll talk a little more about that as we get into segment 4. We'll do a video and notes explicitly on that segment of the syllabus that talks about the comprehensive essay. I'm not going to do any comments today on the text, and I'm hoping you're reading here. There's some good stuff in here, by the way, in the way of comprehensive essay. Take a look at some things there, maybe for some ideas. Go back to that World Health Organization paper on social determinants of health. Begin taking a look and thinking about that. And next week in the discussion, when we start segment, I'll post a discussion thread for the network, but I'll also post a discussion thread for the paper, so that you begin talking about, or the essay, you can begin talking about, this is what I'm thinking about the essay, what do you think of what I'm thinking about, and all of that. So we can get an essay discussion going on through the month of November, as well as an essay, as well as a discussion going on segment 4. So I think that's it for today. There are notes out there, and I'm going to go next into the discussion, see what's up, and then go up and begin grading the postings that you've put up there for segment 2. So thank you for your good work and your patience, and talk to you next week by video, eh?